presentation this morning is rheumatoid wrist and hand, although I'll take more of the principles of managing a rheumatoid wrist that you can take and apply to any part of the distal upper limb. It's a big topic. I'll touch on the pathology, some of the management applications before we discuss specific surgical options in detail. So rheumatoid arthritis is an inflammatory arthropathy predominantly affecting the synovium. The prevalence in our community is approximately 3%, and it's got a predilection for the female sex, with women affected approximately 4 times more than men. Causative agents is mostly immunological mediated arthritis. However, there is some suggestion that there's a genetic susceptibility. Certainly twin studies show a greater concordance between monozygotic twins and also specific genotypes. The HLA-D4 genotype has been shown to have an increased susceptibility to developing rheumatoid arthritis. The essential mediating factor is rheumatoid factor, which is the catch-all term which is used to describe the autoantibodies which are directed towards immunoglobulin in the patient's serum. In particular, actually I'll come back to that in a moment, when these autoantibodies start targeting patient's own cells, especially those of the synovium, there's an acute inflammatory reaction which is mediated by the usual culprits, TNF-alpha, interleukins 1 and 6, which can then descend into a chronic picture of inflammation with release of proteolytic enzymes, leading to a chronic synovitis and erosions of the periarticular joint surfaces and the cartilage surfaces, giving rise to that classical appearance of rheumatoid arthritis. This then manifests in our patients as joint instability and subluxation of those joints. To make the diagnosis of rheumatoid arthritis, one has to have a good going clinical history, and that's at least 6 weeks of a symmetrical polyarthritis associated with an elevation of the erythrocyte sedimentation ratio. Specific rheumatoid factors, ANA, may be elevated, although an isolated elevation of ANA alone is not diagnostic. Anti-cyclic citrinolated peptide is much more specific for rheumatoid arthritis. In fact, 70% of patients who have elevated anti-CCP do indeed have rheumatoid, however relatively insensitive. And so not all patients with rheumatoid arthritis will have an elevated anti-CCP. Biopsy has a limited role in the diagnosis of rheumatoid arthritis. Biopsy of the synovium only shows chronic inflammatory changes, and the characteristic appearance on X-ray is that of periarticular erosions, which you can see here and here, joint subluxation, and arthritic changes, including loss of joint space and subchondral sclerosis, which you can see in the carpal bones on this image. When taken in a surgical context, the management of patients with a rheumatoid disease really ought to be multimodal, in close association with a rheumatologist who can maximise the biological treatment of their rheumatoid arthritis, and close communication with an orthotist, a physiotherapist, and also a social worker, given that these patients have a tremendous burden of other disease and indeed have a shorter life expectancy second to their chronic inflammatory state. The initial stages in managing rheumatoid arthritis, as we'll know, are not surgical, but rather to modify disease activity, bringing inflammation under control as soon as possible using quick-acting steroids such as methylprednisolone or oral prednisolone is the initial first step, and then ongoing disease modification using drugs such as methotrexate, or if methotrexate is not well tolerated, leflunomide, with addition of sulfasalazine or hydroxychloroquine. The older drugs such as penicillamine or gold are used less and less these days. In addition to bringing the initial inflammation under control and also attempting to modify the natural history of disease, you can also have symptomatic relief directed towards the patient's pain and inflammatory symptoms using usual non-steroidal anti-inflammatories, unless contraindicated. Coming more to our side of the management, when we see patients who have deforming disease of the wrist or the hand, we need to take into careful account who we're operating on and why we plan to stage our operations. And so for the patients themselves, we need to take into account their factors, which would be their expectations from any operative intervention, including the long-term success, what their current level of function is and what they hope to preserve, how far their disease has progressed and whether there's any room for biological optimisation before putting knife to skin, assessing their nutritional status, especially patients who've been on methotrexate long-term. Naturally, careful examination is always important in orthopaedics, but none more so in the patients with rheumatoid disease, whose deformities present difficult challenges for us to correct. And there's also need to give consideration to the timing of your surgical intervention. I'll come back to that last point shortly. We're all quite aware of the swan neck and the boutonniere deformity from our days as medical students, but in addition there's a real spectrum of rheumatoid changes that you see elsewhere. Again, we'll focus on changes we see at the wrist. So on the left here we have the hourglass appearance, which occurs in the early asymptomatic stages of wrist rheumatoid arthritis, where you get a synovitis surrounding the synovial sheaths of the extensor tendons underneath the extensor retinaculum. The next image on the right here shows a caput ulna, where you get subluxation posteriorly with distal radial ulnar joint instability, leading to this bulging appearance here. The deleterious effect of caput ulnar is to put excess wear on the tendons, the extensor tendons that pass there over. With chronic changes and disease progression, you get a palmar subluxation of the carpals and also an ulnar drift. I wasn't able to find a good image of an ulnar drift. And here we've got severe wrist rheumatoid arthritis with frank radio-ulnar joint subluxation and dislocation, which you can often elicit a piano key sign where the ulnar soleate is reduced, and then as soon as you remove the weight of the finger, it subluxes again. I mentioned a moment ago timing of our surgery for patients with rheumatoid arthritis. Any intervention that we would plan to do needs to have clear aims in these challenging patients, and they would be to decrease the pain that they feel, improve the function that they can experience with their rheumatoid hand and wrist, and to try and limit disease progression. Essentially, you don't want to be planning for surgery until you're convinced that no further optimisation could be gained from medical management. And the authors of a recent JOS article suggested after a period of 3 to 6 months of intensive steroid initially, and then methotrexate plus or minus sulfasalazine and hydroxychloroquine. They talk about starting your surgeries on the lower limb prior to doing the upper limb, because any patient that has need of a gait aid or assistance while ambulating will have limited benefit from a distal upper limb procedure when they have an arthritic knee or ankle and they continue to load that joint excessively. And when we do get to the upper limb considering surgical interventions, there's the way up between a severity of a distal deformity versus correcting any shoulder or elbow deformity. Again, the same point applies, where there's little point in having a very functional wrist or a pain-free wrist when one has a severely painful elbow or shoulder which prohibits use of that upper limb. So very broadly, the procedures that one can do can be broken down into these categories I've put up. Prophylactic surgery is that which is considered early, and that essentially is excision of tendons, excision of synovium to try and halt disease progression and to limit tendon rupture, and also to control pain. Once tendon rupture has occurred, reconstructive procedures such as tendon transfers can be considered. In more advanced disease, pain control and joint stability can be obtained from procedures involving excision of bony structures with or without interposition of nearby soft tissue. Arthroplasty can also be considered in the upper limb, as can fusion. So to talk about some operations in particular, so considering a tenosynovectomy, really what we're trying to do here is offer the patient pain relief, and the indications for that would be for people who have active disease despite treatment. So that 3 to 6 month window that I spoke about, where biological treatment had failed to halt their disease progression. There is little point in performing this operation in the ankylosed joint of the wrist or the carpal bones, given that they'll have little benefit of improved motion in a joint that's already stiff. And there is some evidence that tenosynovectomies can work. And so a retrospective review of 91 patients that had extensor tendon synovectomies of the extensor retinaculum showed that a radiological study showed that the carpal height measurements, that is preventing the palmar subluxation and ulnar drift, can be prevented. And a lower level of evidence, expert opinion, has been suggested that there's a lower level of tendon rupture in patients that do have tenosynovectomies. Here's an example of a tenosynovectomy. This is an extensor retinaculum tenosynovectomy, and so the authors of a recent JOS article advocate a midline dorsal approach to come down onto the extensor retinaculum, split it, and to raise a flap to be used later. A neurolysis of a terminal branch of the posterior interosseous nerve can be performed to decrease wrist innervation as a pain control procedure. Whilst there, any bony prominences, such as Lister's tubercle or any bony prominence of the ulnar head, can be excised. And using this approach, we can also use excisional methods, such as a Darich procedure or a suave Kapanji. I'll return to the Darich later. And as I mentioned before, that can have good results. After prophylactic surgery, we have reconstructive surgery with tendon transfers. And so those whose disease has progressed such that they lose their extensor tendons, you can perform a side-to-side repair. And this picture here shows some examples of different ruptures. So here we've got rupture of extensor digiti minimi, which is being repaired with reflection of extensor indicis, and a side-to-side repair there. The distal part of extensor indicis is preserved by, again, reflecting one of the extensor digitorum tendons across. Another procedure for tendon transfer that can be performed is to help prevent that palmar subluxation and ulnar drift that I talked about before, and extensor carpi radialis can be transferred across to have a side-to-side tendon transfer to extensor carpi ulnaris. I don't have an image of that, I'm afraid. After the patient's disease is presented, and after it's known that they've got ongoing disease where reconstruction is not possible, a pain relief procedure is excisional arthroplasty. And here's, for example, the Darich procedure, whereby the ulnar head is excised well short of the radiocarpal joint. And this is a management for distal radial ulnar joint instability. Obviously, this isn't the first-line treatment, and this would be selected for less active patients. So usually, extensor carpi ulnaris is preserved in this procedure, although for people who have ongoing pain or ulnar abutment, despite having the Darich procedure performed, you can also perform a tenodesis of extensor carpi ulnaris or flexor carpi ulnaris and have pronotal quadratus interposition between those two bones. Again, this operation can be done through that same midline dorsal incision, which I showed you an image of before. Fusion is another option for these, for patients who are experiencing pain and loss of function of the small joints of the hand. It can either be a limited or a total. This slide I'll consider limited fusion, and in this situation one can perform isolated fusions of the radiolunate joint or the radioscaphoid joint. And the indication for this is for patients who have only mild arthritic disease of the carpal bones and with sparing of the mid-carpal row. It offers pain relief and stability while still maintaining some movement of the wrist, allowing for some function. So there's supination, opening a jar type ranges, and personal hygiene. Again, this can be done through a dorsal midline incision with synovectomy around the wrist capsule. Cartilage between the two bones to be fused is denuded, and then the orientation of the carpal bones is restored, and any acute translation restored. In the setting of chronic translation, returning it to the anatomical position that carpal bone should sit in is associated with more risk than benefit, more disability and pain for the patient. So in the setting of chronic subluxation, you would leave the carpal bone where it is. Bone graft can be used, and fixation methods that we're all familiar with, such as K-wires, plates or screws, can be used to hold the fusion together. For this radiolunate fusion, they haven't used any forms of fixation together, but have a good union there. Total fusion can be considered for patients with much more advanced disease, where there's little to be gained from soft tissue procedures or from a limited fusion. So these are those who have severe arthritis. The trade-off with fusing pan joint fusion is decreased function, especially those activities like opening a door, turning a screwdriver, or even activities such as personal hygiene or doing up getting dressed in the morning and doing our buttons. Fixation methods that we can use include an intramedullary nail. That image below shows a nail passing through the distal radius into the third metacarpal. And that patient incidentally has also had another fusion distally. Or we can use a plate and screw method. And this one is in approximately 5 degrees of extension, which is suggested allows for the patient to retain more function after their fusion has been performed. Arthroplasty of the wrist has been flagged. It's much more popular with patients because it preserves function. However, there are much higher complication rates with having this procedure performed. Although I couldn't chase down figures offhand, the complication rate is still considered to be unreasonably high in patients with rheumatoid disease of the wrist. The complications really being loosening of the componentry, soft tissue ruptures over the prosthesis, although whether this represents the prosthesis itself or a progression of the disease activity, dislocation of the prosthesis and periprosthetic fractures. As I mentioned before, talking about soft tissue procedures for rheumatoid arthritis of the hand and wrist, there really is a whole spectrum of procedures that we could go through. Obviously flexor tendon repairs, carpal tunnel releases and other procedures, excisional procedures such as a swath Kapanji. However, the aim of the presentation today was to provide an overview of approaches to managing problems with patients with rheumatoid hand and wrist, and those approaches that I've described for the wrist can also be applied as principles for management of the metacarpals and phalanges. So just to wrap up, the mainstay of management for rheumatoid wrist is really disease modification prior to surgery being needed. Having said that, there is a role for surgery, and patients can have benefit for an operation if there is a willing surgeon. There's a variety of soft tissue and bony procedures that can be performed, but appropriate preoperative evaluation and selection of patients is important. Any questions?